Good morning. So welcome back for the fourth lecture in the cardiovascular section of 452. Today we're going to move on. We've sort of gone down into the heart all the way to the level of molecules that signal contraction, excitation, and conduct electricity. We've looked at how those go together in a cell model, or how cells work and function to produce repolarization. And today we're going to talk about the next level of integration up. So we're going to go from the cellular organization of electrical impulses and how that continues up into the organization of impulses as they move through the heart, and of one particularly important disease process, that is when that electrical control system fails and you produce an arrhythmia. So normally, electrical activity moves through the heart in an orderly fashion. You want the atrium to contract before the ventricles, and you want the ventricles to contract at the same time of each other. And it's the electrical properties of the cells of the myocardium and the electrical connections between these cells that really determines the way that this orderly behavior propagates, where this electrical activity propagates between the cells and through the tissues. So electrical properties of the cells are propagated through the tissue through electrical connections between these cells, and this determines how things go. And when you have abnormalities in propagated electrical activity, sometimes you will have, say, lack of sinus rhythm, and you will need a pacemaker. That's one form of arrhythmia. Another is when your heart beats too fast. That's known as tachycardia. Another form is fibrillation, where your ventricle is activated in an almost chaotic fashion. And so these are known as arrhythmias. You'll note that they are in color, some of these terms, and underlined. That makes them fairly important. Now, sort of one of the key things to understanding the cellular behavior is, unfortunately, this picture in the book. And I'll put it up here again to warn you off about it. You are likely to get confused if you study this picture. Why? Well, not really because of the first thing. So fast sodium channel does tend to depolarize the membrane and put up the upstroke. There is some K conductance active during this notch. Calcium does not go out through a channel. It goes inward through a channel. So there's a balance between calcium and potassium that's ultimately won out by potassium at the end. So this becomes almost entirely an outward potassium current. Not really much in the way of inward sodium current unless you have a genetic defect called long QT syndrome. And finally, at rest, you definitely don't have bidirectional fluxes of sodium. You are dominated largely by a K conductance with a small background inward leak current, perhaps carried in large part by sodium. So you are likely to be confused if you study this figure. It's got some errors in it in your book, and I wanted to alert you to that so you know that for the test. A much better figure to study is this one here of cellular electrical activity. Important things to remember about it are that it is not to scale, but it does give you a little bit better idea of the timing of things. You have the sodium current going in very quickly and rapidly, not on scale. This would be, compared to these other currents, completely off the page here. Calcium current, smaller, much slower, active during most of the plateau, perhaps more than so than is actually shown here. Sodium-calcium exchange can go inward or outward. It's a relatively small current, but then you have anomalous inward rectification here of IK1. Inward rectification, an important concept. It is something that helps us minimize the energy usage of these cells and helps us produce that long, slow repolarization phase. That means that you produce less current at positive potentials, even though you're farther away from the reversal potential of IK1. Again, I'm going to iterate that the inward rectifier means that it passes inward current more readily than it passes outward current. It still has to follow thermodynamics. It still has a reversal potential. The reversal potential is determined by the Nernst equation. So potassium is only inward below its Nernst potential, and even though it doesn't pass very well with inward rectification, it is net outward above that. It has to follow the two. Inward rectification simply refers to the shape of the curve, not the direction of the current. A transient outward current, pretty much what it says, transient and outward. Turns on and off, mediated by K. So you have these different K currents that are active. You may have more than one component of this inward-outward transient K current. And then you have two slow delayed rectifiers. That's much easier to understand than this picture here, which deals with conductances and shows that you have this anomalous IK1-like behavior of the conductance. So normally, you have propagated electrical activity. And through most of your tissue, with the exception of those nodal or slow tissues, it passes as a wavefront of the sodium-mediated upstroke. So that sodium-mediated upstroke depolarizes the tissue, it depolarizes the particular cell, and then it starts to depolarize the cells nearby. So a well-defined upstroke is absolutely critical to the rapid spread of electrical activity. If you don't have a big current source, you can't supply the cells nearby quickly and depolarize them up to their threshold. So we have fast activity in the His-Purkinje system, the His bundle here, the His-Purkinje system, going out to, and we have it in the ventricles, and we have it in the atrium. So the working myocardium and the His-Purkinje system are all fast tissue, sodium-mediated upstrokes. The sinoatrial node is different. It's a nodal tissue. It has a very slow intrinsic pacemaker rate. That's where your electrical activity is initiated. It does that, as we said before, largely because it doesn't have an IK1 and works as an unstable oscillator. So it always oscillates, produces beats. It's calcium mediated and therefore propagates relatively slow. The AV node can also produce pacemaker behavior, but at a much slower intrinsic rate than the SA node. So it's only if you're in real trouble does the AV node take over as your pacemaker, and you may have an episode of syncope and pass out if that's the case, because it goes at a very, very low intrinsic rate relative to the sinus node. But it also has this slow upstroke and the slow current, so that you have a big delay as the electrical impulse rapidly goes through the atria. It reaches this region here, and so there has to be a tunnel through this fibrous resistive material that separates the atrium from the ventricle, and in that is your AV node. Things go very slowly through that, so your atrium have time to contract, push that last little bit of blood into the ventricle before the ventricles then stop relaxing and start contracting, so that you get these nice and full. You get that atrial kick in that pressure volume that we saw before, fills up that ventricle, and then the ventricle pumps the blood out, and you want it to rapidly go. So here's the sequence: SA node, pacing away, oscillator, it goes to the AV node, which can pace at a much slower rate, but is nice and delayed. And finally moves into the working myocardium. So a nodal tissue, as we discussed last time, has basically a very simple action potential relative to that of, say, the ventricle or the His-Purkinje system with that notch and the transient outward current. It really has what's known as a phase 4 diastolic depolarization. Diastole refers to that slow, or that period where your heart is relaxing and filling. So this is in between when your atrium and ventricle are beating. You have this diastolic depolarization. That is, it's not a resting membrane potential, because the resting membrane potential will be flat. We keep going up and up and up until we hit a threshold where that calcium current starts to turn on. When that calcium current starts to turn on, it depolarizes the membrane more quickly. More quickly you depolarize, more calcium current you turn on, until you get an all-or-none depolarization and this upstroke. And this calcium-mediated upstroke then repolarizes as that slow delayed rectifier turns on, calcium channel inactivates, and you return to your diastolic depolarization, which occurs in part because the K currents, or that delayed rectifier K current, is starting to decay with time, and also you're building up some of that hyperpolarization activated current. And you may have some contribution from other fluxes, such as the sodium-calcium exchanger, which will modulate that. Fast propagation, however, requires a large current source. And that's why atrium and ventricle have this fast, abrupt wave here, phase 0 depolarization. This large current source is necessary because you have to depolarize the area around cells. Now, this is going back a little bit earlier in the book to the squid axon action potential, talking about propagation in a cylinder, which an axon has got a fair approximation to. And it really starts out the same thing for propagation of electrical activity in the heart, with some differences. But the basic things go here. If you excite an action potential here, in this depolarized region, you have turned on your sodium channels, you have reverse polarized, or depolarized, and so you have a net positive charge on the inside and net negative charge on the outside in that region. Next to it, the tissue, or the axon, is just the opposite. You have positive charges here and negative charges here. What happens to negative charges and positive charges when they're in proximity to each other? They attract. The basics from physics. And that generates your current flow here. Your positive charges tend to move to the region of depolarization, and in the inside, your depolarized potential tends to move positive charges down towards things sitting at the hyperpolarized range of potentials. And so you get these loops of current surrounding the region of depolarization. These loops of current. And so these spread out, they're confined within the intracellular space, but in the extracellular space, they go looping out progressively further and further out into the solution. So you have this idea then that the current here, where it's constrained inside the cell, sort of proceeds longitudinally along the cell from this region of depolarization. And it'll proceed either direction if you stimulate in the middle of a cell or an axon. And that means that current flows from the depolarized zone into the polarized zone in this. And as you progressively depolarize this, if there are active sodium channels there, what happens? Well, you depolarize it, you open up some sodium channels, more sodium channels open, and that change in the surrounding tissue serves as a trigger for this type of behavior. So one of the problems with propagated electrical activity is it takes a certain amount of current to charge a certain membrane capacitance up to a certain voltage. So if you have a leaky membrane, your electrical gradients tend to dissipate over a particular area. So if you depolarize a bit and you have a very low resistance in this way and a fairly high resistance through the cell membrane, you have a much more even spread of potential. If you have a low conductance, say through the membrane, and a high conductance, a low resistance and a high resistance in the actual membrane, that will tend to dissipate a little bit faster. So when you give an impulse to a cell, again, plumbing analogies are quite apropos here. How many people have seen those soaker hoses that people use in their lawns? They have little holes in them that go the entire length, and you put some water in them. So again, water is like pressure here. So you're starting to inject some voltage or pressure at one end, in the middle here, and it's at a certain pressure. It's going to have a certain current flow with it. Current flow would be like injecting water pressure here, and in your hose, as it leaks out, you get movement of the water. The water goes through a resistance. Each time it leaks out, you lose a bit of pressure. And so what ends up happening is near the point where you've attached the hose on one of those garden soaker hoses with the little holes, you get water that goes up pretty high. As you get 20, 30 feet out on that, you're watering a pretty small area. It doesn't go very far up. This is the same thing stated electrically. If you've got a big diameter hose and not many holes in it, you keep a fairly uniform sort of pressure. If you have a small diameter hose and a lot of holes in it, you lose that pressure really quickly. And that spatial spread of pressure, of course, determines how much of the tissue you're going to excite how quickly. So there's a relationship between the membrane conductance, the membrane resistance, and the spatial spread of flow. And so this is something taken from Flavio Fenton and Elizabeth Cherry's website. They're right here in upstate New York, and they are looking at and modeling action potential movement. And so you can see here this sort of behavior. They have a cable of cells, cardiac cells here, and they're looking at how the action potential will behave in time and voltage at a particular point or over the entire cable. So they start stimulating here periodically, as you would. You'd have an electrical impulse arriving in the heart, and it starts to depolarize a bit of this membrane. As it depolarizes that membrane, you see that it goes through a repolarization and such. So if you're measuring, say, at this point here, you can see the action potentials I've been putting up on the screen. Sort of with time, you have standard behavior, rapid upstroke, repolarization. But this reflects something that's the same, but moving in time. Rapid upstroke, repolarization, depolarization. And you can see how this excitation from cells that have been depolarized is spreading into the neighboring cells. Those neighboring cells then are having that sodium current turn on. As more of that sodium current turns on, they generate a rapid upstroke. And so you, you get this regenerative propagation. And so the active properties of your sodium channel are very important for understanding how the action potential propagates. So you get, in time at any one point, the action potential looks pretty much like what we've been looking at on a cellular basis, and then it has also a spatial distribution to it as it moves through the tissue, where parts of the tissue would be depolarized and parts of the tissue would be repolarized. Now, one of the things we've talked about is this current flow here. This is generating current flow in time and also in space. And we talked about how these loops can go way, way out into the tissue. In fact, they can go very, very far out into the tissue because your blood and your extracellular solution, it's all salt water. So you're a pretty good conductor by and large. You got some high resistance spots where you have keratinous membranes or keratinous epithelia and such, like your skin, but you can actually detect that current flow from the heart at the body surface that's going through this spatial organization. So long as it's a big enough source, you can record it at the surface. And that gives you the EKG, or ECG, electrocardiogram. We tend to use the K because of the original spelling of it by Einthoven, where K would have been with a, cardio would have been with a K. So we have sinus rhythm here. How do I know it's not a normal sinus rhythm? Because of the sequence of events. The sequence of events, we have this little bump here, P wave. That's usually due to the atrium. It is due to the atrium depolarizing. This QRS complex here is due to the ventricle firing, and then then repolarization gives you this T wave. So we'll go over that quite a bit more detail here. So this spatial organization actually has a manifestation at the body surface that can be measured directly. And that's what you see when you see those little blips going up in basically every hospital scene and every TV show I've ever seen. You have this electrocardiogram going on. It actually means something, is an important diagnostic tool, and tells you something other than being a dramatic way of displaying when the patient dies. It has, as I said, a P wave. The P wave occurs from the atrium firing, the activation of the atrium, and it's sort of over a large space because it's a relatively small tissue, say, compared to the ventricle, and it's covering a larger area. It's a smaller wave. We have the QRS complex, a fairly complicated thing that relates to the firing of the ventricle. That sodium current during the ventricle is the largest, best coordinated electrical event in the heart, and so it has this huge electrical gradient, generates very large currents from the sodium current, which propagate easily to the surface. Very easy and large, but somewhat complicated event, which has two components, QRS. And then as the ventricle repolarizes, unlike the atrium where we can't really see repolarization because it's occurring too slowly, in the ventricle we can see the coordinated repolarization as the ventricle starts to relax, and that's manifested as the T wave. And so that tells us a few things. The PR interval gives us an idea of the delay at the AV node. And one of the things that can happen is if that AV node gets damaged through an infarction or some other thing or through drug action, you can have what's known as AV block. And you will start to see a disconnect between the P wave and the QRS complex. So this gives us an idea of the delay through the AV node. The QRS to T wave interval, we have an ST segment that has something to do with the delay between depolarization and repolarization. It also can have something to do with that notch and be elevated in situations such as Brugada syndrome. This QRS complex, its width and strength, tells us a little bit about how coordinated that electrical activity is. It's a fairly complicated process, developed well over 100 years ago, and this shows a not very happy looking guy hooked up to some 1800s, turn of the century, high-tech equipment. In fact, this was originally used what was known as a string galvanometer in order to measure the electrocardiogram. So electrical impulses were being measured. You see this guy, he's got his hands in buckets of salt water. Why would he have his hands in buckets of salt water? Well, he needs to make good contact through the skin, and we didn't have the nice gels and such and worked everything out the way that we have now. And so these are his electrodes. And so each one of those is an electrode. He has two arm electrodes and what is supposed to be a neutral or ground reference electrode at the foot. And that foot or ground electrode, sort of a neutral, is important in helping eliminate things that are all around us that occur and can contaminate an EKG, like what's known as the common mode signal, but you can think of that as being your lights. And so the electrocardiogram is really measuring, the electrical activity of the heart as it's depolarizing and repolarizing from one spatial area to another. And you're measuring it right out the right arm, but the right arm you can think of as being a point in this triangle. So you have right, left, and of course, way down here at your foot being the neutral. And as this vector goes around, that is, that wavefront of electrical activity moves around, you get different parts of the heart excited at different times and going on. This has been extended a lot past the simple EKGs that we'll be talking about, which will be simply the 3-limb lead ones. But to let you know, these get much more detailed. One of the common things is the 12-limb lead set of things, and so you would wear a whole host of electrodes precisely placed on your heart. And the reason for that is to sort of get an idea of which parts of the heart might have the bigger electrical problems. And it's sort of a very coarse type of mapping of the heart. That is inverse square law. You remember an electrical field drops off as the square root, as the square of the distance, 1 over the square of the distance, the way you are. So if you want to see one part of the heart or isolate it, you get an electrode closer to that, more of the signal will be from that, and there are ways of interpreting this. In fact, and so here you can see from the various regions, you can really look at different portions of the electrocardiogram at different times as they fire different regions of the heart. Giving you an idea, if you have something like right bundle branch block, where you would start to get an excitation asynchronous on the right half of the heart versus the left half of the heart, or various other problems. If there's a region of your heart that is, say, infarcted, and it would not have a very strong signal relative to what it would have normally. And so you use these multi-limb lead EKGs to help with your diagnosis of how viable tissue is, and that can go along with NMR and various imaging modalities. And in fact, a really leading imaging modality that's been developed out by Yoram Rudy out in George Washington University, who was here, I guess, a year ago giving a talk for the Herman Rahn lecture, demonstrated or developed a method that combines NMR imaging and very, very precise measurements of tissue density and conductance patterns, so that detailed maps of the electrical activity in the entire heart can be constructed from an array of over 200 electrodes placed on the body's surface. So this is a continuing area of research in spite of having been around for 100 years, as computer power and imaging have gotten cheaper and more effective. Newer and better ways of interpreting electrocardiogram have come along, but the basics of it have remained the same for over 100 years and will remain the same. And it's something that, if an EMT comes to your house and you've had a relative with a problem, first thing you do is slap an EKG on, because it's very cheap, quick, easy, and provides a lot of critical information into cardiac function. So the first thing you need to know, and I've already mentioned it once, but I'll mention it again, is that you have a P wave. This corresponds to excitation of the atrium. So this is the P wave. It's sort of the first in the sequence. You don't see the SA node here firing. Why is that? It fires first. It's way too small an amount of tissue to provide much current. It has a calcium-mediated upstroke, which also provides a little current. It's just too little signal to actually come to the surface unless you actually have your electrodes directly above it. That would mean opening up the chest and putting it there, which is ruins a lot of the practicality of an EKG. So you have your P wave. You have a delay, this PR interval, where you go through that AV node. Again, you don't see that AV node for very similar reasons. The AV node is bigger than the SA node physically, but again, it's still a slow action potential upstroke, very small current source, relatively small amount very small amount of tissue buried fairly deeply in the heart, and so it doesn't produce a signal either. And the next big signal you get is when you hit that His-Purkinje ventricular system, and you get this rather complicated QRS complex that corresponds to the polarization of the ventricle. Now, ideally, that's what it corresponds to, both ventricles at the same time. But as we know from anatomy, there is more than one ventricle, and so you can see some of the difficulties in the QRS complex if you have a dyssynchrony between ventricles. And then finally, we have this T wave, which occurs fairly late with a delay afterwards. And this corresponds to the repolarization of the ventricle. Notice it's a repolarization event. So the ventricle is sufficiently large, and the dVdt, as you go down, is pretty small and slow, but it's so much tissue that you can, in fact, measure a current due to that repolarization. So that's telling us when the tissue is returning to rest and filling, and it corresponds, as you might see overlaid here, between this. You have your QRS complex, you have your ST interval, which is in Brugada syndrome and other things where we have these ST segment abnormalities, or sometimes called J-wave abnormalities, where there's differences in events that occur here, which are proarrhythmic and do have a very bad prognosis for the patients. We have that region occurring in this ST segment, and then finally we have repolarization here. You can see it occurring over a fair amount of time. Again, that would be both in time and space occurring here to give this sort of broad T wave. Upstroke, QRS. ST segment, T wave. P wave not on here because, well, that's a different region of the heart. So we talk about propagated electrical activity. We talked about it as going through a cylinder, like an axon. Of course, cardiac muscle isn't a cylinder like an axon, or even a multinucleated fused cell like a skeletal muscle fiber. It has connections between individual cells. It has intercalated discs. And it has intercalated discs at the ends of the cells. It also has some lateral intercalated discs. And these things not only, they form the electrical coupling between cells. And of course, the electrical coupling is fairly complicated. You have the terminal cisternae connected to the T tubules, not directly, but through the dyadic space and calcium-induced calcium release. But electrically, you are actually coupled from the cell surface way down into the sarcomeres. So you have a lot of capacitance per unit area to discharge. And so this all has to come through these intercalated discs. And you can see how they're spaced more or less at the ends of cells, but also going laterally through the cardiac cell types. And so these provide electrical coupling. It's fairly heterogeneous. You're interrupted with blood vessels, all sorts of other structures in it. But being a biophysicist, we like to abstract things. And so we say, well, all right, there's all this complicated behavior, but at its basic level, we really got only two components. You have stuff that's got to go through the membrane, and the stuff that's got to go through the cells, and through the intracellular space, and through those intercalated discs, or gap junctions. So you have this transmembrane component of resistance, kind of like the holes in the in that garden soaker hose. And then you have your axial resistance, which is this longitudinal flow as the water flows down here. Some of it goes out this way, but some of it goes further down. And this longitudinal flow and transmembrane flow are governed by ion channels. So your transmembrane flow is governed by ion channels. What channels are open, what their voltages are, what the voltage of the membrane is, and the membrane capacitance. How much charge can it store as you go through it? And that determines your transmembrane flow. It's really your cell model. Longitudinal flow has this resistance component. And this resistance, for the purposes of this course, is governed by gap junctions. There is some resistance of essentially of the cytosol. All those internal organelles and the tortuosity do contribute some resistance, but it's negligible compared to the resistance formed by the gap junctions, those electrical connections between cells. So essentially, almost infinite conductance within a cell, and then slower conductance or lower conductance at gap junctions relative to each other's. So most of the longitudinal resistance is due to gap junctions between cells. And this gets even worse when you have disease. When you got this small component, it can be contributed by the cytosol. And there's an even smaller component that can be contributed sometimes by the extracellular space, particularly if you start to have edema, the cells swell, and the spaces basically get constricted very, very highly. But in general, we treat it, for the most part, in terms looking at propagation of electrical impulses as though that resistance is due to the gap junctions between cells. So a gap junction. What's a gap junction? Well, the gap junction is a macromolecular construct in the membrane, and it connects two pieces of membrane together and forms an electrical connection between them. Well, how does it do this? In the heart, it's done these electrical connections are formed by connexins. Connexins is the name of a protein. And in the heart, it's primarily connexin 43. In other tissues, there are a lot of other connexins of differing lengths. That's how it gets 43. It's 43 kilodaltons in size. But the actual protein itself that forms the channel is much, much larger. And so it's formed of hemichannels. So each membrane here has half a channel, you see. It goes through the membrane, and it would go to the extracellular space, except for it forms with another hemichannel on the other side. So you have hexamers of connexins, that is 6 connexin 43 subunits, arranged together with six of them here, form a hemichannel. It goes through one membrane. In order to connect to and go through the other membrane, it has to bind to connexin 43 on an adjacent cell. So pairs of hemichannels assemble to form these electrical connections. You have electrical connections, and you can see it. It's a hole. It's a big hole. And this permits fairly large macromolecules, organic molecules, as well as ions, to pass between cells. So it forms a very functional, high conductance communication between them. They're big holes, as I said. That means they're non-selective. Unlike the ion channels of the cell membrane, the gap junction connexins are largely non-selective. So you can pass potassium, calcium, sodium, you name it, through them. You can also pass phosphates, various other compounds through them. They're very, very large aqueous pores, and you can actually see them. They're so large on electron microscopy, bridging between regions, and therefore you can abstract them as these very high conductance general connections, sort of that. And so we have now two ways that we've talked about, which is longitudinal current flow and transmembrane current flow. So we can think of this as 3 inputs or to a cell, one of which is the cell membrane, and then we can think of gap junctions on one end of the cell and gap junctions on the other end of the cell as the other 2 inputs. So they're getting their inputs from the cells on either side. This is an approximation. Okay, there are usually gap junctions with adjacent cells. You have Y-type shapes, you have various other things. It's an approximation. So propagation, in fact, is not occurring just in one direction. One direction is easiest to conceptualize, but it actually is occurring in 3 dimensions. So it's occurring in an X, Y, and Z directions because your gap junctions are a little bit more distributed than this approximation. And so we start out with our 3 inputs. Current on the left-hand side coming in from the adjacent cell, current from the right-hand side communicating with the adjacent cell, and then current through the membrane. And remind you, with the exception of pacemaker cells, all cardiac muscle cells require a stimulus in order to fire an action potential, regardless of whether they're atrium or ventricle or Purkinje or His cells in general. So, and the difference for that is, and I've emphasized this a lot, so you can pretty much bet you better know this concept, is that the pacemaker cells do not have a stable resting membrane potential, and so they don't need a stimulus. Everything else does. And that stimulus has to reach an all or none threshold. Again, we have this all or none threshold. We bring things up. Here we get a little bit of current injection, we bring things up, we turn it off, we just go back to rest. A little bit more, turn things off, goes back to rest. up to here, and all of a sudden you hit this all or none threshold. Those sodium channels start to open. As the sodium channels open, the membrane is allowing sodium in. That sodium neutralizes the charge on the inside of the cell. The cell membrane depolarizes. You have a big overshoot. The sodium channels inactivate, K, and you go through your preset set of events. In cardiac muscle, then, for the working things, the stimulus comes from the adjacent cells in the propagating wave. You have a depolarized region, say where the stimulus has been delivered, and then you have the current from the inside propagating outside, depolarizing that membrane, hopefully rapidly bringing it up to an all or none threshold, and so on as it propagates through. So if you think about it then as flow through gap junctions, you get this chain of cells here where you have each one is an individual cell connected by a gap junction, and you can think of it as an ordered set of events. A stimulus comes into here from an adjacent cell that's been excited. You see the current come in. It depolarizes this membrane. These sodium channels fire. When that fires, this is still at rest, so it's at negative. This is positive. Current goes in, causes this one to fire, then this one, and then this one. And so it goes in sort of a saltatory type of conduction through these cells. And then repolarization the same way. As this starts to repolarize, it's going to draw current from here backwards through it. And so you have movement of both repolarization diffusion as well as depolarization diffusion. Slow propagation, and you can see it. The faster you can charge this up, that means the more current you have, the faster you're going to go bap, 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 bap through here. Slow propagation occurs as a result of a low intercellular conductance or a high resistance. So you're going to very slowly bring that channel, that next cell, up to its threshold. So if this is being brought up slowly to its threshold, it's not really good to use the sodium current to excite it slowly, because the sodium current is going to turn on, turn off. And so the calcium current provides a slower current. It's inward, it's a small amount of current, but it turns off much more slowly. So it can provide that inward current to depolarize the next cell over a much longer period of time. So this slower conduction requires a slow, sustained current source, that is calcium, and a very low intercellular conductance, that is a high resistance, so that you really only slowly start to fire that sequence of events. And conversely, fast propagation, high intercellular conductance. The more current you can carry through those gap junctions, the faster you can depolarize the next cell. But remember the leaky garden hose thing. The more conductance you have in that direction, the farther out that pressure is going to go. That's the more capacitance you have to discharge. So you need a lot of current going, or sort of, if you think about it, a lot of water to actually maintain that pressure if you have this type of thing going on. So it requires a fast and very large current source to go with that high intercellular conductance. What does the refractory period do in this? We've talked about the refractory period before, and it says, well, you can't fire an action potential if you're already firing an action potential. That's really handy, because that keeps your propagation headed in one direction. If it keeps it headed in one direction, that is, you can't go back on yourself, that helps guard against tachycardia and premature stimuli. Sometimes if a damaged piece of tissue is damaged, it gets leaky. If it gets leaky, it's providing a lot of inward current. It depolarizes the membrane above that IK1 slope region, and it can cause what's known as an ectopic focus in your tissue. And if that sort of ectopic focus, that is sort of a pacemaker that shouldn't be there, is firing at the same time as your regular pacemaker, you're going to get premature stimuli. And that's going to discoordinate the contraction of your ventricles and cause severe problems with dysfunction. So for propagation, you have this property of the action potential. If you get a premature stimulus and something else is following along, and it occurs too quickly, you get a very slow action potential. A slow action potential is going to propagate slowly, so it'll start to follow behind. As you get further and further away and get a premature stimulus, it will occur at approximately the same sort of speed. So again, this transition from calcium in working myocardium, premature stimulus, giving you a calcium-mediated slow action potential, to a slowly transitioning to a sodium action potential is very important. It causes some very, very abnormal behavior. The calcium current mediated action potentials of the nodal tissue are very different in the way that they respond, and they have this only one phase and one mode. So you have calcium currents here, and you have to wait for this calcium current to recover. And that helps say, well, you can really not fire action potentials very effectively very on. It helps keep the slow depolarization going on. So the specialized conduction system, as we've said, helps time the contractile events. Sinoatrial node to atrium, or to AV node through the ventricle, atrium contracting. It's much more detailed than it might look in this diagram. There's an anatomical diagram that's been sort of dissected from the tissue, showing how effective, how widespread this His-Purkinje network is in providing you with your uniform conduction. The His-Purkinje system, and in fact the entire specialized conduction system, are specialized muscle cells that aren't really so much involved in contractile activity, but in the uniform control and spread of excitation of it. So it looks like a nervous system sort of innervating the tissue evenly, but this is actually, these are specialized muscle cells that occur to do this. So we've talked about this business of what happens with a premature event, and how you change the format, and how you go faster, you go slow. And what does that really mean? Well, it's important more because of its importance in understanding reentrant arrhythmias and how you get them and what happens with this type of refractoriness and relative refractoriness. And a reentrant arrhythmia are basically, by definition, things that move in loops on themselves and are self-sustaining. Tachycardia, that is very, very, very rapid beating of the ventricle, and fibrillation are two very important types of reentrant arrhythmias. They occur through a loss of coordination and control of your electrical system. And when you have this loss of control, you start to get this loop of self-excitation. Because once a cell is excited, it can excite a neighboring cell. And as long as there's some cell coupled to it that is not refractory, it will propagate to that cell. And this can form sort of an abnormal set of loops. And the Wolff-Parkinson-White syndrome is in the textbook as an example. And it's an example there because it's got a very nice anatomical sort of interpretation to it. That is, you have this problem of collateral pathways between the atrium and the ventricles. Normally, everything has to go through the SA node or the AV node. Wolff-Parkinson-White syndrome, you can have some tissue that's developed and goes through from at an abnormal spot from the atrium to another point in one of the ventricles. And what that does is it causes non-uniform excitation of the heart. And so we have this region of block here. Normally you might have one pathway to go through, but if you got two pathways. Well, this is part of the timing is everything sort of aspect of cardiac arrhythmias. If you have this and it goes through, everything is fine. You just go through two different pathways, you excite, you meet in the middle, two wavefronts hit each other, everything is excited, everything is refractory, you can't go anywhere, the rest of the tissue excited perfectly normally. So an extra pathway 99% of the time or even more, maybe 99.99% of the time, doesn't matter. Your heart beats a lot. So even small percentages are going to cause problems if they occur. So let's say you get really excited and you get sort of what feels like an extra heartbeat. So your heart rhythm changes very quickly, and it comes down to these connections between the atrium and the ventricle, and the tissue's refractory. Well, what happens? Nothing. You basically just skip that beat. You hit it, it's refractory. So nothing really happens, not particularly bad. Then what happens if you come down and one side's refractory and the other one's not, or it's damaged or it's not present? Well, this is sort of the normal case. You only have one pathway through the atrium to excite the tissue, and everything gets excited and then contracts and relaxes. It's not a problem. You've got block in one of those branches. Problem is what happens when there's slow conduction and transient refractoriness or unidirectional block. So you have now an impulse that goes down here, coming down from your atrium, and it's got its two pathways to the ventricle. And as it comes through, it hits this region, which is, let's say, still refractory from the last beat. Well, that doesn't matter much. It stops, and this continues on. And you go around the tissue, and you go around the region of block here, that fibrous tissue. You come back. Now, you're no longer in your refractory period, but you've moved to your relative refractory period. Well, what happens then? Well, you get your relative refractory period, you fire a very slow action potential. That slow action potential goes through here very slowly with a big delay. In that amount of time, then, this area has had a chance to recover. So now it's no longer in its refractory period. And you go through there, slowly, you hit this, it propagates through, around, and then around and around and around, and there's nothing really to stop it. And so you get what's known as a reentrant arrhythmia. That propagation wave keeps going around and around and around through this region of slowed block in one direction over and over and over again, producing very, very rapid heart rate. So you have what's known as transient block and slow propagation. Another way that this can happen is anatomically. Remember that a small current can't really excite a large amount of tissue. It will fail to bring it up to its all or none threshold. So if you have a particular geometry of this region, say due to damage, you can propagate an action potential this way, and it will not propagate through the tissue that way because you have to excite a large amount of tissue, say, with a very small hole. But going the other way, the anatomy may be much more narrow. And so you slowly excite tissue from the other direction, so the small amount of tissue is only activating a smaller or more progressive amount of tissue, and you can get anatomical unidirectional block. So it can go one way, but it can't go the other. So the same sort of event then occurs here. You come down, it can't go through this way. You go through, it goes through this way just fine, and you get reentrant block. So unidirectional block, and the delay is allowing the tissue to recover sufficiently, are the conditions for reentrant arrhythmias. These reentrant arrhythmias are self-sustaining. Once they get going, there's nothing really to stop them, except for maybe, if you're lucky, the next heartbeat coming down from the sinus node. So they can occur when there's a non-conducting region, something for it to propagate around, that region of block. So this non-conducting region, and either unidirectional block or an unfortunately timed transient block. And this is drawn in sort of a one-dimensional triangular formulation in your book, but in point of fact, within the heart, you have a three-dimensional organization, and so it can occur in 2 or 3 dimensions, and we call those spiral waves for 2 dimensions, or a vortex, sort of like a tornado, if you were, an electrical tornado spinning around a spot, in 3 dimensions. So you have this business here. You need something to make it go one way but not the other. You only need one of those events, though, and then the whole thing becomes sustaining. So unidirectional block or transient block effectively acting as unidirectional block. Some delay so that the timing can work, and that will set up this reentry, and you will just go around and around and around this very, very quickly. And in fact, you will go back up and excite your atrium and perhaps even suppress your sinus node, depending on the general health of other tissue. So we have this here. Now this unidirectional block, or this it could be caused by anatomy, or it could be caused by timing. That is, changes in the refractory period. And that's why this repolarization and repolarization abnormalities become so important, because you kind of need, for a spiral wave to happen, you need that triggering event. You need something there to trigger it. And so you have triggered arrhythmias, which can, of course, set up and develop sustained arrhythmias, or you have or they're actually arrhythmogenic all by and of themselves, as they disrupt the organizational flow of action potentials. And in general, we talk about triggered events in 2 types: early after depolarizations and delayed after depolarizations. And they're fairly easy to interpret. Early after depolarizations are sudden depolarizations of the membrane that occur early. They occur during late repolarization. So they start out, and a lot of times they will start looking like excessive action potential prolongation, which might occur under a certain thing, behavior. And this excessive action potential prolongation has excitatory currents that during that repolarization there, we're generating sodium-calcium exchange. The calcium current is not completely inactivated. And so you have this interaction between sodium-calcium exchange and other currents that can give rise to a problem there. It's often associated with bradycardia. Bradycardia means slow heart rate. And so when you get a very, very slow heart rate, your action potentials tend to get very long, and that's when you have a tendency towards these. And these are found frequently in the phenomenon of long QT syndrome. Long QT syndrome is an arrhythmogenic diagnosis from the EKG, where if the interval between the QRS complex and the T wave gets to be excessively prolonged, I believe that's by more than 10% over normal, you tend to have a patient with a propensity towards sudden cardiac death and arrhythmias. So long QT syndrome can be acquired, and it can be genetic. It's oftentimes, and its most important clinical manifestation, is that it occurs as an adverse drug reaction where drugs either diminish the potassium currents relative to those calcium currents on which they balance during the action potential. And so here we have cells that have been treated, and you can see the development of early after depolarizations. You go from a fast cycle length, everything's fine. You go slow cycle length, you start to see this excessive prolongation of the action potential until finally it actually regenerates and fires in a second action potential. And if you go very, very long, you will start to see that all the time. And these runs can get very, very long and oscillatory before they stop. And so these are EADs. They can be caused by block of potassium currents, enhancement of calcium currents, and various genetic defects. And then you see bradycardia, that is the slow heart rate, will tend to promote these types of behavior. Whereas a fast heart rate, you build up enough additional K current to help prevent these types of arrhythmias. And the reason they're so dangerous is because they can form an ectopic focus and be a substrate for reentrant arrhythmias. So you have this action potential sort of normal, but if it becomes excessively prolonged, you have, of course, a very, very long refractory period. You have the problem of causing transient delayed block. You also can have a triggered event which will propagate in a different direction. Delayed after depolarizations are associated with high heart rates. They're associated with calcium loading. So you get too much calcium in, you're not effectively pumping it out. You have ischemia or some other problem, and so you've got this high calcium loading in the heart. The SR takes it up. Eventually the SR can overload. It'll dump some of its calcium at an inappropriate time during the action potential, during the diastolic phase, and cause a contraction. And these can also cause reentrant types of arrhythmias. And you can see here the difference between them. You go beating along very quickly, you cease, and you'll see an action potential trying to happen here. And if you go with more and more drug block, or more and more calcium loading, you can actually, through a faster rate, you can actually produce a series of oscillating action potentials occurring well after the membrane is repolarized. That's the big difference. The ADs are from the resting membrane potential, EADs are during the action potential. And so they organize themselves to give you types of arrhythmias. And you can see these on the electrocardiogram. Here, you can see normal heart rhythm, and that's your orderly progression of excitation and repolarization. If you set up a loop, say around a region of block here, or some other thing, you have these waves that are going very, very fast and occur in a fairly orderly fashion. If the tissue starts to get these ectopic beats, that is EADs, DADs, each one of these wavelets will break up until you finally get this disorganized or chaotic type of behavior where action potentials are just propagating through the tissue. This is what's known as fibrillation. And fibrillation has been described as being similar to your heart looking like a sack of worms as these excitatory action potentials sort of go through and around various portions of your heart, but the sack of worms is not a particularly effective pump. And so you see actual photos here of this type of electrical behavior in real hearts using voltage sensitive dyes. You can see stable spiral wave here in a heart undergoing ventricular tachyarrhythmias, so very, very fast heart rate relative to normal, and then fibrillation where you get very little signal because the signals are so very, very uncoordinated. And that's where we'll leave it off today. Thank you very much.